Hey podcast listeners, Fawaz Al-Mufti here from Westchester Medical Center, New York Medical College, and I'm your host on the Neurocritical Care Society podcast. While early management of aneurysmal subarachnoid hemorrhage is aimed at stabilizing the patient, controlling hemodynamics, and optimizing cerebral physiology until the aneurysm can be secured, subsequently the focus shifts to allowing cerebral autoregulation at higher cerebral perfusion pressures for treatment of cerebral vasospasm and delayed cerebral ischemia. The pathophysiology of vasospasm is complex and multifactorial to say the least. Cardiogenic neurologic complications of aneurysmal subarachnoid hemorrhage have been postulated to be secondary to sympathetic nervous system modulations at multiple points of several pathophysiologic pathways and have been associated with poor outcome. The multiple avenues through which sympathetic modulation can affect neurologic and cardiogenic sequelae of aneurysmal subarachnoid hemorrhage makes it an interesting strategy to improve outcomes. Today you'll be listening to Lucia Rivera interview Aravind, Ramesh, and Matt Thomas on how they sought to study the role of beta antagonism in aneurysmal subarachnoid hemorrhage and the relationship of beta-blockade with mortality. I hope you enjoy this episode.
Welcome, podcast listeners. This is another episode of the Neurocritical Care podcast. My name is Lucia Rivera, and I'm a neurointensivist at Johns Hopkins in Baltimore, Maryland. Today, we will be discussing Beta-Blockade in aneurysmal subarachnoid hemorrhage, a systematic review and meta-analysis published in Neurocritical Care Journal in 2020. It is my great pleasure to introduce the first and senior authors for this paper, Dr. Aravind Ramesh, who is an academic intensive registrar in the Severn region in the UK, and has just finished a National Institute of Healthcare Research Academic Clinical Fellowship. He is due to start a doctoral fellowship this year. We also have the senior author for this paper, Dr. Matt Thomas, who is a consultant in intensive care medicine at South Mid Hospital in Bristol, UK, and the clinical research specialty lead for critical care in the West of England Clinical Research Network. Welcome, Dr. Ramesh and Dr. Thomas, and thanks again for accepting this invitation.
Thank you very much for having us.
Before we get to the details of the paper, I want to first talk about a shared interest that probably most of our podcast listeners share, which is our interest and passion for research. So I would like to ask you, what inspired you to do this work?
So I guess Matt and I both work in a major trauma centre here in the UK. We see quite a lot of neurocritical care specifically, and I think both of us probably would agree that we haven't, in the last sort of 20, 30 years, been able to make huge inroads into real disease-modifying treatments for many of these patients with acquired brain injuries, and so anything that potentially might improve outcomes for some of our patients, I think is something that's worth investigating. So this is part of a kind of a wider interest, certainly at Southmead Hospital, in improving outcomes in neurocritical care.
We all know that aneurysmal subarachnoid hemorrhage is a life-threatening type of hemorrhagic stroke and a neurologic emergency with high mortality and morbidity. And even though the worldwide case fatality rate has been decreasing in the last 2 decades, the pre-hospital mortality remains pretty high at 15% and the 30-day mortality at 35%. Not only that, but 1/3 of the patients report a reduction in health quality of life care at 1 year from the event. What I find really interesting is that there is an extreme elevation in the sympathetic nervous system activity that persists up to 1 week after the event, which is the aneurysmal subarachnoid hemorrhage. And this increase in sympathetic nervous activity has been associated with the development of neurogenic stone myocardium and cerebral vasospasm, which are the known complications for aneurysmal subarachnoid hemorrhage. So talk to me about this activation of the sympathetic nervous system that occurs after aneurysmal subarachnoid hemorrhage, which is probably the premise for the use of beta blockers on this population.
Yeah, that's exactly right. So I guess you put it quite nicely in that I think aneurysmal subarachnoid hemorrhage is a fairly common neurosurgical emergency that we see. It disproportionately affects a younger patient group. And so the societal and economic consequences are pretty significant. So anything that potentially might improve outcome seems like a good thing to investigate. There's kind of reasonable observational data, if you like, both in terms of retrospective case registries, but also looking at measurement of catecholamine levels after ICTA, so after the aneurysmal subarachnoid hemorrhage, that suggests that the sympathetic nervous system is overactive, and that activation appears directly linked to some of the complications you mentioned. So both intracranial complications such as vasospasm or delayed cerebral ischemia, as well as extracranial complications such as the cardiovascular complications that you talked about. And that these complications impact significantly on outcome, both in terms of mortality, but also significant morbidity associated with aneurysmal subarachnoid hemorrhage. So this kind of sympathetic overactivity potentially offers a therapeutic avenue to go down in terms of trying to attenuate that overactivity to see if it improves outcomes. So that was really the premise for conducting this study.
Yeah, I find that very, very interesting. Can you give us a summary of the final studies that were done on this topic prior to your decision to proceed with this meta-analysis that have shown that beta blockers may be beneficial as a therapy in these patients?
Yeah, so there was actually a previous systematic review meta-analysis which looked at beta-blockade in this population cohort, but they only looked at cardiac-related complications and actually only included a few studies. And their conclusion actually that there wasn't really a particular effect of beta-blocker therapy. But actually, since the publication of that study, there have been additional observational studies. And if you sort of a cursory search of literature would suggest that there are some prospective clinical trials that suggested benefit. There's also kind of the observational data that I talked about, specifically measuring catecholamine levels. So I think there was biological plausibility that attenuation of this system might be beneficial, but also both retrospective and some prospective trials that might suggest that there's a kind of actual patient-centered outcome benefit to all of this.
So you decided to put all this data together. Talk to me about the methodology for your paper. How did you combine these different studies that may have, different definitions for the outcomes that you were trying to measure?
So you're absolutely right, and I think that's we point that out. I think in the paper that one of the limitations with this type of analysis is it does depend significantly on the quality of studies available. Essentially, the preliminary data that we had seen didn't suggest that there was a specific drug, so a specific beta blocker, or a specific dose, or a specific timing. So our inclusion criteria really were quite broad because we wanted to capture as much of any potential signal as possible. So we included all studies essentially that looked at adult patients with aneurysmal subarachnoid hemorrhage that looked at beta blockade in that group. And so we looked at both observational studies as well as randomized controlled trials, and both pre-admission beta blockade as well as post-event blockade. And I think the key really was really being quite clear at specifying what our outcomes were and what additional kind of groups we were looking at analysis in. So the primary outcome that we were looking at was all-cause mortality across all of these studies. So looking at the impact of beta blockade at any time point on mortality. But importantly, our kind of exploratory hypothesis was that delivering beta blockade in the immediate period post-ictus, i.e., directly trying to attenuate the sympathetic activation that we talked about might be of most benefit. So we looked specifically at post-event blockade versus pre-event blockade to see if there was any difference. But other than that, in terms of methodology, it was a systematic search through the kind of fairly standard databases, so Medline, Embase, clinical trials registries to look for other publications. And then we kind of effectively a systematic review team to screen out titles based on title and abstract initially, followed by full text screening to identify those specific studies.
What were your findings? Were you surprised by some of those results?
I guess our prior hypothesis was that beta blocker therapy might be beneficial. So it certainly was very interesting to see that there does appear to be a signal in the literature when you pull the studies together that beta blocker therapy is associated with reduced all-cause mortality. I think what was quite interesting is that a lot of that seems to be driven by post-event beta blockade. So if you look at studies that look prospectively after ictus, there is potentially a significant signal of benefit there. Compared to studies that looked at pre-admission beta blocker therapy. We were probably expecting to see a signal in terms of some of the extracranial complications. So particularly you mentioned neurogenic cardiomyopathy, and we didn't really see certainly a significant benefit in some of the secondary outcomes that we looked at, which perhaps we were expecting to see.
What about cerebral vasospasm and delayed cerebral ischemia? Did you find any interesting results with those outcomes?
So we didn't demonstrate that there was a significant benefit of beta blocker therapy. For most of the secondary outcomes, there seemed to be a trend towards benefit, but certainly none that we would describe as with particularly robust. So no is a short answer, and I guess that was another outcome that we hypothesized might be affected by beta blocker therapy. Having said that, one of the problems I think with studies investigating vasospasm and delayed cerebral ischemia is that those studies are pretty heterogeneous, and so definitions of what constitutes vasospasm and delayed cerebral ischemia have certainly changed over time. And so it is quite difficult, I think, to compare and collate some of those studies, particularly for that endpoint over the other ones. I think you're right. It was quite difficult. If you look through from the paper, the studies looking at vasospasm all pretty much use different definitions of vasospasm itself. And then the studies looking at delayed cerebral ischemia or delayed ischemic neurological deficit, specifically looking at stroke, there were not many studies specifically looking at that outcome. So I think you're right. There wasn't a huge amount of data, and the data was very heterogeneous in terms of delving into it. I think interestingly, the one outcome, so the delayed cerebral ischemia outcome or actual stroke, was the one outcome where we didn't really actually show even a trend in the direction of benefit from beta blocker therapy, which in itself is potentially interesting. Although it may just be that there's no effect rather than a signal of harm, potentially.
I think again, touching on that heterogeneity, it's not just the definitions. We were gathering together a group of studies from multiple continents, multiple centres, and multiple times. So practice in the 1970s and 80s was very different to practice in the 2000s. So yes, I think this highlights the point you made earlier about the difficulties of meta-analysis when the studies identified are not the most strong methodologically. And it is hard to get real consistent practice-changing messages from these studies as they stand.
So were there any other limitations that you would like to highlight besides the heterogeneity of the studies, the lack of data, the fact that, there was a big lapse between the studies, like I think you mentioned in your paper up to 40 years. Are there any other limitations that we should highlight?
I think a significant limitation is the fact that we obviously included both observational data as well as randomized trials. And so, out of the 13 studies that were included in the quantitative meta-analysis, only 5 of those were prospective interventional trials. I think, interestingly, when you look at those prospective trials, specifically the same message, that kind of the headline message of the paper is still borne out, which I think is reassuring, that kind of there's consistency of message. But I think that's quite important, in addition to the heterogeneity that you talked about, the fact that we've got significant time span and kind of methodological differences between papers. Matt, I think had more.
Yeah, I would support that point. Is that we are seeing consistent direction of effect, no harms, but the publication bias as well was impossible to assess, and we can't exclude an important effect of that as well.
So we see that there is sympathetic activation in many illnesses, which is usually a defense mechanism. So why would you want to block it? Could it be rather a protective mechanism for the brain to keep normal hemodynamics, as well as, like the cornerstone of like neurocritical care in many of these conditions, including aneurysmal subarachnoid hemorrhage, is to maintain normal hemodynamics on these patients who have loss of cerebral autoregulation and many times depend on that increased SMAP that sometimes even we have to assure with vasopressors. So talk to me about this concern that I feel many of our listeners may have of blocking this protective mechanism that, we do see that it is, there is an overactive autonomic sympathetic system, but is it like the chicken or the egg? Like, are we seeing that there is this increased activity, but maybe the brain needs it to protect, and have a normal cell perfusion pressure to keep normal function, or maybe the opposite. So talk to me a little bit about that.
I think we sort of make a comment in the paper. I think that those concerns are entirely legitimate. There was a neurocritical care published a letter to the editor from some colleagues in Colombia, I think, Nino et al., which raised exactly the same concern. I think that's certainly a legitimate concern. I think it's important to bear in mind, firstly, that the findings of the paper don't advocate for practice change at all, but they advocate that there is certainly a signal there and a plausible biological hypothesis that warrants further investigation. There were very few studies in the studies that we looked at that actually reported on adverse outcomes at all. Of the studies that did, none of them reported hypotension as an adverse effect, but certainly the absence of reporting doesn't necessarily ensure safety. And I think part of what we would advocate going forward is that we need to be very clear that any further clinical trials studying this area focus on safety primarily to begin with, to establish what the appropriate drug, what the appropriate dose, and what the appropriate timing might be that's tolerable in these patients. Matt might certainly have further thoughts on that.
I completely agree with what you said. I think there is a natural assumption that because the body does something, it's appropriate for that situation. But what we see in people who survive subarachnoid hemorrhage, or in other situations like traumatic brain injury or severe sepsis, where this catecholamine surge is prolonged, that it is potentially harmful for reasons such as immunosuppression or arrhythmias, or even other unknown effects of adrenaline. One of the ones that we are investigating in traumatic brain injury is actual endothelial damage and a compromise of the blood-brain barrier. So just because it happens and it does have an obvious effect of supporting blood pressure, it doesn't mean that this continued sympathetic drive is actually beneficial. And it's trying to find a balance that between the two, getting the benefit of maintaining perfusion but preventing harm, that is a very difficult tightrope to walk.
The kind of surrogate that what we're really interested in when you talk about cerebral autoregulation is flow and cerebral blood flow, and it's certainly not easy to measure that. And so the surrogate that we're using, which is mean arterial pressure, is at best a surrogate. And I think it's important to bear that in mind, that artificially, using vasoconstrictors to increase mean arterial pressure doesn't necessarily follow every time that you're improving cerebral blood flow to injured areas of brain.
When I was looking at your paper and, I started thinking about this link or this finding of, catecholamine surge after aneurysmal subarachnoid hemorrhage that we have been discussing, we all know that, this catecholamine surge activates not only beta, but also alpha receptors, right? And that, the associated links that we discussed with myocardial dysfunction, etc. What do you think about the use of alpha blockers? Like, I think in your systematic review, you review beta blockers, right? Are there any studies done on alpha blockers?
Might have to defer to Matt. I don't know if he has any.
Yeah, there are some of the early work, particularly Neil Dwyer and colleagues in the 70s and 80s, who were really amongst the first neurosurgeons to use autonomic blocking drugs. They were using both beta blockers and alpha blockers in their studies. Phentolamine, I think, was the one that they used. But that, for whatever reason, hasn't continued. And I think it is part of the question. It's part of the uncertainty as to, how you use drugs to modulate the autonomic nervous system and its response. But the weight of evidence, I think, both in subarachnoid hemorrhage and in other areas of critical care is with Beta-Blockade alone. But I think the point we make is that it's a hypothesis generating, and it may be that alpha blockade is important, and we shouldn't forget it.
So what would be the take-home message for our listeners? I guess, from our discussion, we're not advocating for beta blocker to be adopted as a standard of care in management of these patients. What would be the take-home message that our listeners should get?
I guess the take-home message is that there appears to be a potential signal of benefit. Beta blockers are fairly cheap. They're an existing drug that physicians are very familiar with, and certainly on ICU we're very familiar with. And I think we would advocate that further clinical trials in this area potentially would be very useful. I think the start of that process has to be oriented around safety, so dose finding, feasibility and tolerability of specific drugs, dosing and timing to establish what's safe, and then larger kind of multi-center trials to actually look for benefit. I think the bottom line is many of the studies that we've looked at, as we've kind of said multiple times during this podcast, carry fairly significant methodological issues, and probably would be arguably a low quality form of evidence. So I think it highlights an unmet need really for higher quality evidence in this area.
Do you think then the next step is more studies in humans? Do you think it will be worthwhile to go back to animal studies and attempt to see signals, like a larger signal for this?
My personal feeling is that these are, as Aravind has said, these are drugs that are well established in medicine in humans, and that if we want to find out how to treat human patients, we should do research with human patients. There aren't particularly good models of subarachnoid hemorrhage in all its complexity, and even traumatic brain injury, particularly with the changing populations that we're seeing present to hospital. So my take-home message, I think, as we say in our response to the letter, is high quality collaborative research to investigate these issues.
Completely agree.
Thank you very much for joining us. I think this is extremely interesting. I am really looking forward to seeing more studies on this topic in the near future. And I hope that our listeners enjoy our conversations.
Thank you very much for having us. That was really interesting. Thanks.
Thank you. Thank you.
Thanks for listening to the NCS podcast. The NCS podcast is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, education, and advocacy in neurocritical care. Our production staff includes Tariq El-Maghribi, Andrew Barishmet, Leonid Groisman, Atul Kalanuria, Lauren Kaufman, Cassie Cronfield, Holly Ledyard, Lindsay Marchetti, Alexander Reynolds, Lucia Rivera Lara, John Rosenberg, Jason Siegel, Zachary Threckle, Teddy Yoon, and Chris Zaman. Our administrative staff and senior producer is Bronny Rousseau. Music by Mohan Katapali from the University of Miami Division of Neurocritical Care. If you like our show and want to learn more about us, check us out on Twitter, Facebook, or LinkedIn. The NCS podcast is available on NCS On Demand, iTunes, and wherever you get your podcasts. I'm Fawaz Al-Mufti, and thanks for listening.